So may I start? Did you finish?
Dr. Sami, Dr. Ahmad is with us.
Is with us?
Yes, he just joined.
Okay, so may I start?
Yes, doctor.
So good afternoon to all.
لا ما في صوت.
Dr. Sami, you are muted.
So good afternoon to all from MENA area. Just to start our activity of today, we have now 81 participants from MENA area attending our activity. So on behalf of CRG, Dr. Fadi Farahat and AMAC myself, we are a pleasure to have you all in our activity ABC Oncology Educational Course, which will be today about Gyna-Onc. We have excellent speakers from Jordan, Lebanon, Egypt, and I will let the floor to our chairman, Dr. Ahmed Sikutori. Dr. Ahmed Sikutori, he is consultant gynecologist and gynecology oncologist, and he is professor of obstetrics and gynecology. Excuse me, because I didn't see good, I don't printed it. He is in Egypt. Please, Dr. Ahmad, the floor is yours to start presenting our speakers for first session, and the panelists will discuss the two lectures which will be given by our colleagues.
Thank you very much. Assalamu alaikum, Professor Sami, and all professors and colleagues and friends from the MENA region. It's an honor and pleasure and privilege to be part of this educational program. Let us start by really an exciting and a very good lecture that has been really the discussion and a subject of debate over the last few years, talking about the ovarian cancer in the era of precision medicine, the role of PARP inhibitors, by Dr. Ali Shamsuddin. And he is a professor of clinical medicine and director of gastrointestinal and genitourinary cancer program at the Hematology Oncology Division and Basel Cancer Institute at the American University in Beirut. Okay, doctor, go ahead, doctor.
Thank you, Mr. Chairman. I will share my slides. So we'll talk today about the role of the PARP inhibitors in the treatment of recurrent ovarian cancer. This is my disclosures. So as you know that when we are treating, when we are putting plan for treatment in ovarian cancer, we have several lines, including the surgery followed by chemotherapy or neoadjuvant chemo followed by cytoreductive surgery. And we left what we call the minimal residual disease, and either we go for observation and this subsequently lead to regrowth of the tumor in most of the cases and relapse and then subsequent treatment, or we use what they call maintenance therapy, aiming to reduce the minimal residual disease and delay relapse and subsequently hoping for a cure. So evolution of maintenance therapy in relapsed ovarian cancer came from more than around 10 years with the approval of bevacizumab in the maintenance therapy through the GOG 0218 and the ICON-7 trials. And subsequently, molecular targeting recently, we have several trials that approved the role of the PARP inhibitors in patients specifically with the BRCA mutation. And here we'll concentrate in two main trials, the SOLO-1 and the PAOLA-1 trials. So the objectives of the talk today will first understand the unmet need in ovarian cancer first, and second, to have overview on the PARP inhibitors and the BRCA, the HRD homologous recombinant deficiency role in DNA damage repair, and we'll share the role of the olaparib in the treatment of patients who are relapsed and have metastatic disease with BRCA mutation, and the subsequent treatment of first-line maintenance in patients with HRD ovarian cancer in combination with bevacizumab. The unmet need in ovarian cancer came from these figures. As you know, we have around 300,000 new cases of ovarian cancer, but remember that 60% of these cases were relapsed, and around 30 to 50% median 5-year survival of these patients. So remember that most of these patients that present for treatment will relapse in the first 5 years. And again, you can see here that the patients who are presented with a distant disease represent around 2/3 of patients, while those with localized disease only 15%, and the regional disease is only 20%. And again, we can see that the 5 years survival in patients with advanced disease means 3 and 4, stage 3s and 4 reach only 30%. And this is why we need more intensification or more insult into the treatment after the chemotherapy and surgery.
Dr. Shamsuddin, Dr. Ali, before continuing, I'm receiving many remarks that the slides are minimized on the screens. On mine, I see it very well. Can you, Vanessa, verify, please? Yeah, I know. I see it very well on mine, but I've received at least 3 requests from different colleagues that they cannot see.
Yes, how can we correct it?
I don't know. I'm asking Vanessa more in order not to continue before يعني قبل ما نحل هالمشكلة. Vanessa, are you with us? Dr. Bassam Matar, can you answer us? You said that you are not seeing this.
Doctor, it should be working now.
Okay. Miriam Makhloufi, can you please confirm? And just I need confirmation from the audience. At least 3 persons send. I'm sorry for the delay, but in order to resolve it. We are seeing Dr. Ali, it's full screen. We are seeing Dr. Ali and the slides very small. Okay, for those who are seeing small slides and the picture of Dr. Ali big, it's normal because really he's a big guy.
Actually, full screen.
But you have to switch screens. It's on
You have
your
to
screen
switch.
laptop.
It's full
Yeah.
screen, Dr. Fadi.
I
think
know
Dr.
that.
Ali is okay.
ايه بس انه اللي عم بيشوفوها مش منيحة. They have to work on their setting بالسيستم بالزوم. It's not a central problem. It's a local on their computer. Thank you very much. I'm sorry for the interruption. بحب لكم بس نحن we are already at 121 participants. Thank you very much.
Great.
Dr. Ali, you can continue, please.
Dr. Ali, go ahead. Thank you.
Okay, thank you. So the majority of patients with, as we can see here, of ovarian cancer will relapse, specifically in stage 3 and 4. As you can see, 70 to 90% will relapse. So this is the course of treatment in patients with ovarian cancer with the subsequent decrease in what we call the progression-free intervals. So, or the progression-free survival. So the patients, when they are treated initially with surgery and chemotherapy, whether using bevacizumab maintenance therapy, the initial PFI will reach around 1 year to 2 years. Then they will relapse, and then subsequently PFI, as you can see, decreasing in the second line. Then after the third line, we reach only 4 months, and subsequently the disease will progress. So we need more ideas and treatment to maintain these remissions at least for a longer period. So when we have a diagnosis of stage 3 and 4, we have the surgery, then the platinum-based chemotherapy, and most of our patients will go to first-line maintenance therapy. Some of them elect to observe, and the other may go into clinical trials. These are the schema of the treatment of patients with advanced ovarian cancer. And the aim of the maintenance is to reduce the risk of recurrence or delay the recurrence from the initial primary chemotherapy. And this is the progression-free with subsequent relapse or recurrence. As you can see, when we have initial relapse, the progression-free survival decreases gradually until we are on the 4th or 5th line of treatment. Well, it decreases markedly. So what is the role of olaparib and what is the mode of action? So when we have a cellular replication on a daily basis, we have a DNA damage continuously and DNA repair. And this DNA repair either occur as a single DNA strand break or a double DNA strand break. And when we have a single strand break, the repair is, this does not affect the cell survival, and the repair occur with the PARP enzyme that recruit the proteins and leading to the repair of this protein and subsequent allow the replication of the cell. When we have the double strand break, this is the main problem because this affects the continuity of cell growth and subsequently and survival. And when we have a normal proteins in the BRCA1 and 2 that can be helped or induced by the PARP enzymes, and this will lead to the continuous repair of DNA double strand break and subsequent moving to normal life, which is the continuation of cell cycle and subsequent later on cell death. This is the what is happening when we have a sort of a normal repair in the double strands. But when we have a deficient in the repair due to mutation, like in BRCA1 and 2, we got what they call a faulty DNA repair, a weak point in the double strands. And this weak point is vulnerable to the allowing the cells to continue grow and does not include the cells in the normal cell cycle. So they escape the normal cell cycles, what they call the error-prone DNA repair. And this allows the tumor cell to continue to grow. This type of cells or deficient repair of DNA will be a weak point and vulnerable also to sort of break subsequently. And you can see here the accumulation of the defective repaired DNA, this accumulation leading to sort of escape of the normal cell cycle and subsequent cell survival of these cells, and subsequently the survival of this cell will lead to spread of the tumor, increase in size, and subsequent escape the normal death. So when we have a PARP inhibitor here, this will inhibit the repair and subsequently allowing the cell to die. We are talking about the BRCA, but there is other than BRCA, what they call the homologous recombinant deficiency. And this homologous recombinant, when it occurs through other genes, lead also to a double strand break. And this double strand repaired on normal life by the homologous recombinant repair. But whenever there is a sort of a repair deficiency, this double strand where we get what they call the homologous recombinant deficiency, which is other than the BRCA mutations. And this will lead to also what we call genomic instability. This genomic instability can be manifested as duplication of certain genome or deletion, as you can see, or an insertion or translocation. And this will emerge as three genomic phenomena. They call the large scale state transition or the polymorphic allelic imbalance or loss of heterozygosity. Remember that the BRCA mutation and the homologous recombinant deficiency that initiate what they call the genomic instability can be calculated through a system which score up to 100 and score around 42 and above. This considered as significant. So the score below this 42, which used the myriad, my choice genomic instability method, use this score. Below 42, usually it is not significant. So we're using this score to decide on the treatment when we ask for the homologous recombinant deficiency or HHRD or the genomic instability calculation. This HRD, as we said, and this is the data from Paolo 1 trial, you can see here out of the 800 patients, as you can see here, the HRD positive in around 48%, which is almost half of the patient. But remember that the non-BRC HRC, HR occur in 6 to 7% of these patients. And the score is used here, as we said, to define that the patient had genomic instability, HRD genomic instability, when we have a score equal more than 42 or when we have BRC mutation. So we're going to discuss the two trials. The first trial, the SOL1 trial, which defined the patients with BRCA mutation, and the Paula trial, which argued the BRCA mutation, but also they included the patient with homologous recombinant deficiency beside the BRCA mutation. These are the design of the two trials, as you can see here, and we'll talk about each one in separate. So this is the SOL1 trial, which is published in 2018 in New England Journal. But recently we have an date as 5 years with cytoreduction, after cytoreduction surgery in CRBR, then followed by platinum therapy. The patients included 391, randomized 2-to-1, either they received olaparib, 300 milligram BID, or placebo. And this is the treatment for up to 2 years or until disease progression. And the primary endpoint is the investigator-assessed progression-free survival. And this, in the primary analysis and in the published paper, maintenance olaparib significantly improved investigator-assessed PFS. So it was a positive trial. And median PFS with olaparib arm not reached versus 13.8 months in the placebo with hazard ratio 0.30 and significant p-value less than 0.001. And this is the 5-year follow-up. I said the long-term efficacy, tolerability of the 2 years olaparib with progression-free survival exploratory clinical risk subgroup analysis according to the high risk versus low risk, and the secondary point, specifically the progression-free survival to time to subsequent therapy and safety. This is the data as presented, showing of the progression-free survival and at follow-up, as we can see, at 2 years and at 5 years. And the hazard ratio reaching 0.33, significant p-value, with a median progression-free survival, 56 months for olaparib versus 13.8 months for the placebo. And at 5 years, the progression-free was in 48% in patients receiving olaparib versus 21 in patients with placebo. This is the subgroup analysis, high risk versus low risk groups. As you can see, the high risk, these are the FIGO 4, stage 4, or FIGO stage 3 with residual disease following primary debulking, or FIGO stage 3 and interval surgery. The low risk are the FIGO stage 3 without residual disease following primary debulking. And this is the data, as you can see in percentage, for the high risk versus the low risk. As you can see, the patient characteristics and the percentage of CM taken in each group. And this is the follow-up 5 years beyond end of treatment. As we can see here, 56 months versus 13.8 months, difference almost 42 months, with the hazard ratio of 0.33. With the median treatment duration, olaparib 24.6 months, placebo 13.9 months. And this is the difference in the outcome compared to the two groups, the high risk versus the low risk. And you can see here the benefit is clear for both risk groups, either whether the high or the low risk, with significant improvement in the progression-free survival for the high risk 40 versus 11 months, with the hazard ratio 0.35, and for the low risk not reached versus 22 months with the hazard ratio of 0.38 months. This is secondary outcomes, including the progression-free survival 2 for the olaparib at 5 years, 64 versus 41. And for the median progression-free survival to not reached versus 42 months, while the in CR, the patient in CR at the baseline showed a significant improvement progression-free survival from 44 in the placebo to 68 in the olaparib arm, with a median not reached in the olaparib versus 53 months in the placebo. And you can see the hazard ratio is significant. For the time to subsequent therapy, for the 5 years, 62 for olaparib versus 36. And for the patient in CR, 65 versus 39. And the hazard ratio is 0.46 and 0.5. This is the safety, and the safety profile of olaparib consistent with the primary analysis, so no additional cases of MDS-AML reported as a long-term follow-up, and the incidence remained below 1.5%, and it is mostly the grade 3 and above in the olaparib 40% versus 19, and the serious adverse event 21 versus 13. And the interruption, as we expected, more in olaparib, 52% versus 17%, and dose reduction 29 in olaparib versus 3%. Discontinuation more, 12% versus 3, and new primary malignancy equal in both arms. There is no impairment of the quality of life, as you can see here, no big difference between both the olaparib and placebo for the in the quality of life. So in conclusion, the SOLO-1 in newly diagnosed advanced ovarian cancer and BRCA mutation, 2 years of maintenance olaparib produced a sustained progression-free survival benefit versus placebo at 5 years follow-up, with a median progression-free survival of 56 months versus 13.8 months. So SOLO-1 data should be considered standard treatment for women with newly diagnosed advanced ovarian cancer and BRCA mutation. BRCA status should be assessed in all patients with ovarian cancer diagnosis. And the question, what about BRCA wild type patients? As you can see here, and this is data published before, knowing that the homologous recombinant repair genes may have mutation, deletion, amplification, or promoter methylation. And there are other than BRCA, as we can see here. And these are the emerging homologous recombinant deficients that may be sensitive to PARP inhibitors, as you can see. And mostly we have the CDK mutation, CDK12 mutation, very important. And the RAD51C promoter methylation and the HRDNA damage gene mutation. And these are evolving in the HRD and should be tested in most of these patients.
Dr. Ali, we'll give 10 minutes extra to conclude the presentation.
No, man, I started late. This is why.
Okay.
So what about the maintenance in combination with bevacizumab? As we said, bevacizumab and through GOG and study approved for maintenance therapy with improved progression-free survival from 10.3 to 14.1 months. So the PAOLA trial tried to answer this question, whether adding olaparib to bevacizumab as maintenance versus placebo plus bevacizumab in the same category of patients. And you can see the primary endpoint of the study, which in favor of the combination of the olaparib plus bevacizumab with 22.1 months versus 16.1 with the placebo and bevacizumab. And this is in favor of all subgroups, irrespective of the age, FIGO, age, cytoreductive surgery, timing of the cytoreductive upfront or interval, or no evidence of disease versus CR and versus partial response. You can see here the secondary endpoint, favor of the combination, also increase in progression-free survival, 22 versus 16.6. Progression by the blinded committee, also 26 versus 18. Time for subsequent therapy, 24.8 versus 18.5 months, and entering progression-free survival to 32 versus 30 months. Here, the patients with BRCA mutation subgroup showing significant improvement with 32.2 months versus 21.7 months, this category of patients. And the outcome at 2 years was those who are BRCA mutated free of progression at 76% at 2 years versus 39% in patients who are in the placebo plus bevacizumab. And this is for the patient without the mutation. As you can see here, 18.9 versus 16 with the hazard ratio 0.71 months. And here you can see the difference between patients who have BRCA mutation versus non-BRCA mutation. Both groups showed a good difference in the combination with beva and olaparib, but those with BRCA mutation showed a better outcome with the hazard ratio 0.31 versus here hazard ratio 0.71. And as we said, in the solo one, we encountered patients with BRCA mutation only, but here in the patients with PAOLA-1, it includes other than the BRCA mutation. And this is the data in the PAOL-1 showing that patients which are HRD positive, including the BRCA mutation as progression-free survival primary endpoint. And these are the group with the HRD without the BRCA mutation. Both groups showed significant improvement. But when we take the HRD negative patients, there is no difference as progression-free between the two groups. And this is the non-BRCA progression-free survival, but by clinical risk groups. Both showed a positive improvement in progression-free survival, as you can see here. But it is more as HR here is 0.60, and the high risk or the low risk is HR is 0.46. But both are significant, but it is more with the low risk group. This is the adverse events, and it is not difference from the combination. We have more fatigue, asthenia, nausea, anemia with the combination rather than with the single agent. Hypertension also is more. Quality of life does not change between the two groups, as you can see, no difference. And this is the HRR between the patient with HRD positive, but non-BRCA with the HRD negative and non-BRCA also, or unknown BRCA. There is no difference here, but here the progression-free maintained the difference in both groups. So in summary, the PAOL-1 investigated adding olaparib to active treatment with bevacizumab with the intent of the achieving maximum therapeutic benefit. It is a positive trial, and it is the second pivotal trial investigating the use of olaparib in newly diagnosed advanced ovarian cancer, and the only phase 3 trial that used the combination of the PARP inhibitor with the bevacizumab in the maintenance setting. In a representative patient population unselected by biomarker stage or surgical outcome, olaparib added to the bevacizumab achieved a statistically significant improvement in progression-free survival versus placebo, with a 22 versus 16 month with other 0.59. And among the around 50% of patients in PAOL trial where HRD positive olaparib added to bevacizumab resulted in statistically significant benefit versus placebo plus bevacizumab, other is 0.33, and PFS rate 2 years, 66 versus 29%. It is well tolerated and consistent with the previous knowledge about the use of PARP inhibitor without change of quality of life. We know we have the PRIMA trial that examined the same effect of the solo with using niraparib. And it gives also, it is not, here we cannot also compare trial by trial, but it gives a similar outcome for both groups, but more in number with the olaparib. As you can see, median progression 56 versus 13 months, and a difference around 42 months, while here 22 versus 10 months with niraparib with a difference of 11 months. And again, this is the PRIMA and the PAOL trial about talking about the patient with HRD ovarian cancer, and the difference here also was significant in favor of the olaparib 32 versus 17, while in niraparib it is 21 versus 10 months, and the difference is 11 months. And the patient without HRD you can see with bevacizumab, there is improvement in the progression-free survival only. In the Paula trial, no improvement in progression between the two arms. Although here in PRIMO, we have numerical improvement in the progression by 2.7 months. Does we need bevacizumab with olaparib? This is, we don't know. No head-to-head comparison between PARP inhibitor versus bevacizumab plus PARP inhibitor in BRCA mutated ovarian cancer. But two trials soon to open will hopefully provide data to answer this question. And the indirect data showed some improvement here from the population-adjusted indirect comparison using the combination olaparib-beva versus olaparib showed some improvement in outcome with a 12 months progression-free for the combination 96 versus 88 for single olaparib and 24 progression-free months progression-free survival for the combination 82 versus 73 for the single agent. But we are waiting the final. So this is the schema for the treatment of advanced ovarian cancer with the use of neoadjuvant followed by debulking or debulking followed by platinum-based chemotherapy. Then we have to move to the maintenance and the maintenance therapy in patients with no BRCA, no HRD negative. We may use bevacizumab single agent, but in patients who have BRCA mutation, we can choose in maintenance with olaparib, a single agent, or patient with HRD positive, they can use the combination as the Paula-1 trial. I will stop here and thank you for listening and ready for any question.
Thank you very much, Dr. Ali. Let me say this is one of the really very informative, up to the point talks about PARP inhibitors in ovarian cancer that I listened to recently. That leads us to really a panel discussion of three of the eminent doctors and physicians in our Arab world. Firstly, Dr. Nisreen Khazem. She's an assistant professor in medical oncology in Damascus University in Syria. Welcome to us. And also Dr. Ehab Al-Rayyan. He is a consultant obstetrician and gynecologist at King Hussein Cancer Center in Jordan. Welcome. And also Dr. Abdullah Al-Tal, and he's a consultant medical oncology at King Hussein Cancer Center in Jordan. Welcome all to the panel discussion of 10, maximum 15 minutes on the talk of Dr. Ali Shamsuddin, also interacting and taking questions from the chat from the audience. Thank you.
There is one question. I think Dr. Nisreen want to present the first question.
Dr. Ali, thank you. Thank you very much for this imperative presentation. Actually, Dr. Bassam Matar asked you about how about comparing olaparib plus bevacizumab or versus olaparib. Do we have any data? Do we have any clinical trials in this schema?
Yes, the last two slides, I answered this with the last two slides about the population based. We have some data in favor of the combination versus single agent, but there are two ongoing trials, so we are waiting this question from the two randomized trials.
Okay, thank you, Dr. Ali.
I have a question for Dr. Ali. As we know that most of the data are for cases with advanced ovarian cancer and those with positive BRCA mutations, but still some oncologists may suggest providing the PARP inhibitors for cases with early stage ovarian cancer. with BRCA-positive mutation, especially those with stage 2. So would you comment on, is it a proper way for providing the PARP inhibitors as a maintenance therapy after the surgery for those patients?
Yes, it is a very good question. Sure. We don't have till now data examining the use of the PARP inhibitor in early stage ovarian cancer, because as you know, in stage 1 and 2, the cure rate or the 5-year survival is very high, above 85%. And this is why we have to weigh the benefit versus the cost and the side effect that the patient may suffer. This is an important issue.
Okay.
Vanessa, can you unmute Dr. Basim Bahrani? He has a question. Dr. Basim Bahrani, can you unmute him, please?
Thank you, Dr. Fadi, or Prof. Fadi. What about the use of olaparib in the neoadjuvant setting?
Also, this is a good question. As you know, in the neoadjuvant setting, it means you need a rapid effect. So you need the combination of chemotherapy plus the olaparib. It's not a single agent. So the data also is deficient in this aspect as neoadjuvant, but it may be a good idea to have an insight into this theory and try to design a study for that.
There is a question from Dr. Manal Diglawi, and she's asking, are there any data comparing Avastin combination versus PARP inhibitors alone?
What do you mean?
Well, I don't know. I just read
May I
the
comment on that? May I comment on that?
You mean Avastin with chemo versus PARP inhibitor only?
Maybe she meant Avastin with PARP inhibitors versus PARP inhibitors alone.
Yes, I told you we have the last couple of slides I presented.
This is a question from Dr. Manal.
Yes, I presented there is some difference at 12 and in favor of the combination, but this is post hoc for population data, and there is 2 randomized trial ongoing to answer this question, whether we need really bevacizumab with PARP inhibitor or we don't need it. Specifically in patients with BRCA mutation.
Okay, Dr. Ali. Dr. Ali, I think there is a question of anonymous attendance of our attendants. Who is the best candidate for addition of bevacizumab to chemo?
Which patient?
I don't know really. The question is still bevacizumab. I think in the stage 3 or 4 as maintenance or as I don't know. Maybe our attendants, would you please?
What is the indication? What is the indication?
Yes, our attendants, would you please, or our attendants, would you please clarify your question? So, which patients you mean?
Usually, the beva we added in the high risk groups, as with induction chemo followed by maintenance therapy. Those with stage 4, those which stage 3 with minimal residual disease, or those who have interval debulking, not upfront debulking.
Maybe I have, maybe it will be the last question.
Yes, I think so.
It's regarding patients with and they received the PARP inhibitors after the first line of treatment, and they reoccurred. So the question, the PARP inhibitors with or without bevacizumab after the recurrence?
Yes, if the patient, they have recurrence and they treated again by chemotherapy, maybe they are platinum sensitive, so you can introduce the chemotherapy again, and then again you can introduce the maintenance therapy.
Dr. Ali, I think we have more questions, more than that. Do you think that talazoparib may give a deeper response?
As?
A deeper response?
Do you think that talazoparib may give a deeper response than olaparib?
There is no head-to-head comparison.
Which is impossible to answer.
I cannot answer because no head-to-head comparison.
No. Yes, yes. No head-to-head and no more data.
Yes, sure.
Okay, maybe there is a room for a quick question, if there is.
Last one, maybe.
I think there isn't more questions.
I think we answered all the questions.
All the questions.
Yes.
So maybe we have to thank Dr. Ali Shamsuddin. Thank you, Dr. Ali. We are very thankful for your great presentation.
Thank you.
Thank you very much.
Thank you, Dr. Ali.
Thank you for the invitation.
Thank you
all
for
the panel discussion members. That was very fruitful. Is Dr. Basser Rifki with us?
Yes, I'm here, Dr. Ahmed.
Okay, it gives me a great pleasure to introduce my dear friend and colleague, and one of the really very dynamic figures in gynecological oncology in Egypt, Professor Dr. Basser Rifki. He's Associate Professor of Surgical and Gynecological Oncology at the Oncology Center in Mansoura University in Egypt. And let me congratulate him in accrediting his center as one of the accredited and acknowledged ESGO center in the region. He's probably the first one. He's talking to us about the controversial new vaccine to prevent cervical cancer.
So thank you, Professor Ahmed, for the presentation. So can you hear my voice?
Yes,
yes. Yes, and the screen is clear?
Yes, also.
Yes, also. So thank you, everyone. Thank you, Professor Ahmed, for the very nice presentation. It's always my honor to be with you. I'm always just following your steps. Thanks, Dr. Sami, for Dr. Sami and Dr. Fadi for the nice invitation. It's really a privilege to be among a group of friends and colleagues today, Dr. Ihab, Dr. Fawzi, everyone here. And again, this is an educational course. We are speaking about a controversial vaccine. Really, it is not controversial vaccine. It's already well established. But the controversy is about, do we need it in our region or not, in MENA region? Is cervical cancer is a common problem or uncommon problem? And do we need the vaccination in our region or not? This is what I'm going to speak about today. So we all know that cervical cancer is common among women worldwide, and most cases occur in the developing countries. However, in the developed countries, there is a decrease in cervical cancer incidence and mortality, which are related to the availability of screening programs and the HPV vaccination programs. It's the fourth most common cancer in women worldwide, with estimated 3,041 women died from it in 2020, more than those who died from the COVID-19. HPV infection is established to be the most common cause of cervical cancer. This is well established. But really, it is one of the preventable cancers, and it has been like a red flag that we can eliminate cervical cancer in this decade. The International Gynae Cancer Society, the European Society of Gynecology, as well as FIGO, have launched this global strategy to accelerate the elimination of cervical cancer. We are all embedded to solve the preventable tragedy of cervical cancer by 2030. The global research by IGCS, ESGO, and FIGO will help to facilitate the delivery of national projects integrated within border sexual and reproductive health service to eradicate cervical cancer. So what will be the condition in our region, in Egypt, in our region? We know all that cervical cancer features, it is a highly preventable cancer, one of the few preventable cancers, and it is successfully treated. We have to organize prevention and screening programs again in the MENA region. Let's take Egypt like an example. Egypt is a very big country with more than 100 million population. So do we have, what's the epidemiology of cervical cancer in Egypt? Still, this is the global can numbers, and we all know that the registry isn't that accurate either in Egypt or on all the Arab world. We don't have very accurate registry, but still, according to the global can, we have 1,320 new cases annually of cervical cancer, which is the 9th most common female cancer in women aged from 15 to 44 years, and this is a vital age. Still, the astonishing number, or the fearful number, is the mortality, which is around 744 cervical cancer. So we have really more than 50% incidence to mortality ratio. Most of cases of cervical cancer are going to die. So this curable, easily preventable, and easily curable cancer, we are losing more than 50% of the ladies who are presented with cervical cancer. And still, we have a very enormous estimated disability adjusted life years, with around 8,233 years of life lost, with 784 years lived with disability they can't do, and they are not an active members of society due to cervical cancer. So today we are speaking in an educational course about the HPV genome and the HPV affection. We all know that HPV is many viruses that cause replication. There is the classification. There are 53 generations in the family papillomavirus, along with the new papillomavirus and the new papillomavirus. So all these HPV types are currently, we have more than 200 HPV types which have been identified by the international HPV reference centers. Again, we have the HPV, which is causing either the mucosal sites of infection or the cutaneous site of infection. Around 40 types cause mucosal site of infection, and around 80 types cause the cutaneous site of infection, which are common, which we know as hand and foot warts. Let's go to the 40 types which cause our subject of today, which are the HPV, high-risk oncogenic HPV. Most common are HPV 16 and 18, and we have to concentrate on that. And then the lower-risk non-oncogenic types, which are 6 and 11, which are most common. So the most common are 6, 11, 16, and 18, with 16 and 18 being the most risky. Those cause cervical cancers, not only cervical cancers, but anogenital cancers, oropharyngeal cancer due to the oral sex, cancer precursors, and low-grade cervical disease. Again, the low risk will cause genital warts, laryngeal papilloma, and low-grade cervical disease, and they may go to cervical cancer as well. So it's a problem not only for the gynecologist, but again for all the oncologists in the oropharyngeal cancers, the esophageal cancer, and in the anal cancers and vulval cancer. So the alpha papillomaviruses, all of these are classified again into group 1, which are the carcinogenic 16 and 18, sorry, and the low risk, which are 11 and 16, and the probably carcinogenic, like the other types of human papillomavirus. Sorry for that. HPV 26, HPV 53. So the HPV prevalence in Egypt, is it a prevalent disease in Egypt? We had a multi-center observational study by Shaltut et al. In between 2010 and 2011, and they stated that the overall prevalence of HPV in Egyptian women was about 10%. This is a very big percentage, 1 of every 10 women. But the newest study by Al-Azab et al. Was published between 2019 and 2020, and they said that the overall prevalence of HPV in Egyptian women is around 14.3. This is a very high percentage, really. So we have to prevent HPV, primary prevention by HPV vaccination. This is the most efficient method for primary prevention. we give number of doses. We start at the 9 years old before sexual practice or before the age of marriage. So we start with the girls in the school age, either by 2 doses at 0 and 2 months later before 15 years old, or we go for 3 doses after 15 years old. The first is 0, then after 2 months, then after 4 months, or after 6 months from the second dose. So we have either 2 doses before 15 years old or 3 doses after 15 years old. The recommendation in the USA is up to 26 years old, but still they can give up to 45 years old. It's still if you are not married or you don't have sexual practice, or if you have just limited sexual problems. So the vaccines which are available now are either the bivalent dose against the 16 and 18, which are the most common, or the Gardasil, which is the tetravalent or the 9-valent. Really, in Egypt right now, we don't have the 9-valent, but we have the 4-valent or the tetravalent vaccine against 6, 11, 16, and 18. It's available now in Egypt, and we use it really. And then we have the secondary prevention by screening method, by the pap smear cytology, HPV testing, and co-testing, which is that. And the recommendation are, as we all know, below 21, you don't have to do screening. Between 21 and 29, you have to do the cytology alone every 3 years. And between 30 and 65, you have to do the cytology plus HPV testing, the co-test every 5 years, or cytology alone every 3 years. And after 65, no screening if you have 3 consecutive negative cytology for 2 consecutive negative 10 tests within the last 10 years. So you don't have to screen, because just yesterday, I received the results of a woman who is 69 years old, and she had screening, first time screening for HPV with atypical cells, and she told me what to do. I told her, why ever you do screening after 65, just for cervical cancer? If you have low-grade disease in intraepithelial neoplasia, it will turn like many, many years. So what's the problem in our region? That really we don't have established screening program all over the region, all over the MENA region and the Middle East, and we don't have accurate registry about the numbers. We have to have accurate registry first, and then to identify the magnitude of the problem, the magnitude of mortality. Do we have to pay for a screening program? Do we have to pay for the vaccination on a national level or not? And still, we don't have widespread vaccination in most of the countries in the MENA region. They are not aware about the vaccination. There is no awareness about the presence of vaccine, even among doctors, even among gynecologists. Sometimes they ask me, is the vaccine available? Is it here? Yes, it is here and it is available. So there is no awareness. Most of the non-gynecologists or the surgeons or whatever, they don't know that there is HPV vaccine and it is against cervical cancer and it is a totally preventable cancer. These all are very new data for them. Again, we claim that we are conservative countries, we are some religious countries, so it is a disease of sexually active females, and so we claim we don't have HPV infection. And again, all the studies that stated that the percentage is between 10% to 15% of women state that this is again what we believe. It's highly prevalent to be transmitted now sexual practice. And again, we have many people who have multiple sexual partners. The partner is away from another. You don't know anything about practice. So still, we don't have to bury our head in the sand and say this is not disease in our country. Interpreted as cervical cancer and for the screening and vaccination programs, or they are not interested. They are just interested in the IVF, in the obstetric part, and they are not interested. Very few are like Dr. Ahmed Sektouri, who are interested in the gynecological part, in treating the gynecological disease. And most of the gynecologists believe that cervical cancer is not a common disease. We still don't have numbers about that. So oncosurgeons laid over, they made very few early cases. Very few of them are too subspecialized. They do much aggressive approaches with much radical surgeries for stage cancer, node and leaving behind residue on the parametrium, or doing surgery in the advanced approach and the combination of surgery with irradiation. This is not the true. But as long as we don't surgeons who are specialized in gynecology, you will see more and more of unknown cases, not early, even after the LAC trial, which show tremendous overall survival changes between those who had minimally invasive surgery and abdominal surgery. For the irradiation, we have long waiting list for external beam irradiation, very few brachytherapy machines. We don't have the time to do concomitant chemoradiotherapy, as is going in the next presentation to be illustrated. So some use the neoadjuvant chemotherapy followed by surgery with much inferior results than the definitive chemoradi, which should be the standard. And we have the problem of subtotal hysterectomies with many cervical stump carcinomas. All this should raise awareness about doing that. Cervical cancer in Egypt is a reason, is not a surgical disease. We met very few early cases, very few cases who are candidates for colonization or for trachelectomy. I myself have performed only 2 trachelectomies all over my career. I have met very few early cases of cervical cancer due to the lack of awareness about the availability of the vaccine and the screening programs, and that is a common disease. So what we are doing right now to try to prevent that, we're starting to raise awareness about the disease. We are raising awareness about the vaccine. Even I myself in my region, we have vaccinated right now in the last few months more than 250 women with the tetravalent vaccine. And then we established the EGOS, the Egyptian Gynecological Society. It was established last November, and the launching will be just in 3 weeks. And Dr. Ahmed Sektouri is the vice president of the of EGOS. We have to go through the Egyptian Gynecological Society to speak with the international societies and the regional societies about gynecological cancer awareness and the national registry and the need of public vaccination, or even vaccination for those who can afford to have the vaccine away from public programs. And as Dr. Ahmed Sektouri stated, we go more and more to try hard to have the accreditation in Mansoura to be the first accredited center in the Arabic world and in Africa, and one of the very few outside Europe to be accredited center as European training in gynecology, including the vaccination and screening awareness gynecology. That was just last month in September, to be trained in gynecology with the privilege to the gynecologists, not the oncosurgeons. So we use only 2 trainees to be trained according to the ESGO from Egypt, and the other one is outside from Egypt. Up till now, we have around 60 applications from Jordan, from Syria, Saudi Arabia, from Palestine, and of course, we still open the application of November 2021, because we have trainees, most to be trained and then to transmit and then to other, and more people be specialized in gynecology, either in Egypt or outside Egypt. And that's, I invite all of you to know more and more details about the launching of the Egyptian Gynecological Society in the 11th and 12th of November 2021. It will be a hybrid event, so either you can come to Cairo and be our guests, or just go online. And we have the honor to be collaborating with the AMAC, with Dr. Sami Khatib, and it is an ESGO endorsed event, really. And thank you very much.
Thank you very much, Basil, for this really elegant talk, displaying the current status of HPV vaccination and actually prevalence in Egypt as an example of a country in the Middle East and MENA region. Tuning still on the issue of cervical cancer, and we have a very interesting talk to come by Professor Dr. Fawzi Abu Hijla. He's talking to us about the sequential chemoradiation versus concurrent chemoradiation or radiation alone after hysterectomy for cervical cancer. Professor Fawzi is a consultant radiation oncologist at King Hussein Cancer Center in Jordan. Over to you, Dr. Fawzi.
Thank you, Professor Ahmed. I would also like to thank Dr. Sami and Dr. Farhat and the organizers for the ABC Oncology educational courses for this kind invitation. It's really a pleasure to participate again in these courses. Can you see my slides well?
Yes.
Okay, great. So I'm just gonna proceed with the topic. So the talk will be about sequential chemoradiation versus concurrent chemoradiation or radiation alone in the settings of in adjuvant settings after hysterectomy for cervical cancer. I have nothing to disclose. The topics will be for this brief talk about the staging for cervical cancer, the management in adjuvant settings, the current evidence in literature, and conclusion. So at the beginning, let me just remind you with the staging for cervical cancer divided from the oncological perspective, whether the cervical tumor is resectable or non-resectable. So based on the Vigo staging in 2018, stage 1 is where the disease is confined to the cervix. Stage 2 is beyond the uterus cervix, depending on the size. And for mainly the visual disease in stage 1 and bulky tumors in stage 2, please bear in mind that for larger tumors with more than 4 centimeters, although they are deemed resectable, they are still, as per the NCCN guidelines, the definitive chemoradiation is preferred over surgery due to the bulkiness of tumors and higher risk for R1 resection. Continuing with the staging, stage 2B with parametric involvement, whether that is by clinical exam or radiology, there's a gross macroscopic involvement of the parametrium. For stage 3, which is also deemed unresectable for oncological perspective, whether due to the locally advanced disease or local regional nodal involvement, and then stage 4. So what type of surgery is recommended, as Dr. Basil also mentioned briefly in his talk, for early stage, very early stage, stage 1A1 with no risk features, simple hysterectomy might be adequate. A modified radical hysterectomy for 1A1 with lymphovascular space invasion or 1A2, and radical hysterectomy, which is characterized by more paracervical tissue removal, is recommended for stage 1B1, 1B2, and stage 2A as well. Regarding fertility preservation, this is a different topic. It's really used in highly selected early stage cases. Moving forward to the topic, so talking about the role of modalities in adjuvant settings, starting with adjuvant radiation. This was addressed in one of the landmark trials, the Seedless et al., where they addressed the adjuvant of radiotherapy post-radical hysterectomy in stage 1B. And they looked into the intermediate risk features as lymphovascular involvement. So they looked at the lymphovascular space involvement, the stroma invasion of the cervical stroma, and the bulkiness of the tumor, the size more than 2, 4, or 5 centimeters. And you can see clearly the difference, the disease-free survival benefit of adding radiation to this group where there are these adverse features in histopathological specimen after radical hysterectomy, and they classified into 4 main groups where the benefit is still persistent with the lymphovascular involvement with 1/3, no matter what the size is, lymphovascular involvement with 2/3, or superficial involvement with LVI, and the bulky tumors with more than 5 centimeters. Another trials, there have been actually many trials tried to challenge the Seedless criteria, where they're tried to address whether there are other risk features for intermediate risk and whether Seedless criteria is accurate. This study was published recently last year in the International Gynecological Cancer Journal from China with 800 patients. Although it was retrospective, they found that there is an independent risk factors that predicts recurrence. Mainly there was, although 1B and 2A are still deemed to be early stages, 2A has higher risk for recurrence, as well as from the Seedless criteria, the only factor that was found significant on univariate and multivariate analysis actually was the lymphovascular space involvement. Regarding whether which treatment should be done for this early stage group, whether it's observation, radiation, or chemoradiation, they didn't really find a significant difference in relation to the disease-free survival. However, there was higher recurrence rates in the pelvis for the group who didn't receive radiation or chemoradiation. what was the role for adding chemo to radiation when it comes to higher risk group? Not only the intermediate risk group, but also for patients who carries a higher risk. They underwent hysterectomy, and with the histopathology, a nodal involvement was found, or the margin was involved, DAR1 resection, or looking at the parametrium, there was a microscopic involvement. So this was addressed by Peters et al. Almost 2 decades ago, and they found that there are overall survival benefits for adding chemo in adjuvant settings. So they compared radiation into chemoradiation, and overall survival was significantly better in the chemoradiation group. This difference was even more significant when it comes to tumors more than 2 centimeters, and for nodal involvement by more than 1 lymph node. So the role of radiation has been known already with the intermediate risk, and the role of chemo has been addressed also in the high risk group. There was a new recently published trial a couple of months ago this year in JAMA Oncology, which is a randomized phase 3 trial. It's called the STARS trial. And it's pretty similar to the title of this talk, whether sequential concurrent chemoradiation or radiation alone is the best modality after hysterectomy for cervical cancer. So what they did, they looked into patients with 1B to 2A, the early stage who are deemed resectable. They randomized the patients, around 1,000 patients were randomized into sequential chemoradiation. And it wasn't really purely sequential. I would call it more like a sandwich protocol, where there was 2 cycles of cisplatin paclitaxel followed by pelvic radiotherapy, and then another 2 cycles of chemotherapy with a similar regimen. The second arm was concurrent chemoradiation, the one with cisplatin alone, concurrently with radiation around 6 cycles during radiotherapy, and third arm was radiation therapy alone. So they included both risk, and one of the limitations of this study, they were not separated in the analysis. So they included the higher risk and the intermediate risk, and what they found that there was a significant benefit for the sequential regimen over the concurrent and radiation alone in regards to the disease-free survival. And looking in the detailed analysis, the higher risk group, the intermediate risk group, there was statistically significance for when compared to radiation, but not when compared to to concurrent chemoradiation. And also there was significant benefit for the use of chemo, whether it's concurrent or sequential, for non-pure squamous pathologies like adenosquamous carcinoma and the mixed, whether it's adenosquamous or adenocarcinoma, pure adenocarcinoma. So the rationale for these results and for enrollment of this study actually was at the beginning is to use a more effective chemotherapy rather than the one is routinely used in concurrent chemoradiation settings. We know though that the Peters et al. When they did the concurrent chemoradiation study, they used cis-5FU. However, there was a high toxicity rate in that regimen. So routinely, the concurrent chemoradiation is being given as cisplatin, which we know it's more used to augment the effect of radiation rather than working on the microscopic cells systematically. So we know that taxanes with cisplatin would do much better than cisplatin alone. This is the first rationale. The second one is the earlier introduction of adjuvant therapy by postponing radiation and introducing chemo with the median starting date of 8 days in this study. They managed to tackle the cancer cells earlier than the concurrent chemoradiation arm, because radiation has to start sometime between or around, I would say, 4 weeks after surgery to allow good wound healing and avoid toxicity. However, there was a few limitations for this trial. there were a group of patients who received already neoadjuvant chemo prior to surgery, and the both risks were mixed during the analysis in regards to disease-free survival.
Can you please read?
So there are, after I mentioned the established publications in the literature, there are two good ongoing trials that would answer also some gaps when it comes to recommending adjuvant treatment and after hysterectomy. We have the COG-263 trial, which is they completed the accrual, but we're just waiting for the follow-up and the final results for this study. Stage 1 till 2A with intermediate risk who were randomized into radiation or concurrent chemoradiation. The other study is the R2G study, where they randomized higher risk group after radical hysterectomy for, again, radiation alone or chemoradiation. So what we have learned from these trials, I just try to summarize them into points. We know that larger tumor volumes might benefit, they are even if they are resected, they might benefit from definitive chemoradiation. Observation is safe for lower risk early stage cervical cancer, who for patients who doesn't have any risk features, whether they are not intermediate, not high risk. Adjuvant radiation to be considered in intermediate risk early stage, and addition of chemo in adjuvant settings is recommended for higher risk groups and for selective cases in intermediate risk group, mainly when it comes to higher tumor size found on specimen or extensive LVI, I would say. Finally, the sequential chemoradiation has favorable outcomes when compared to concurrent chemoradiation due to the reasons I mentioned earlier. So in conclusion, adjuvant treatment for early stage cervical cancer should be taken on multidisciplinary discussion. We always encourage to have several opinions and reviews. Detailed histopathological assessment to address the risk features is crucial for decision making. And to start with, we know all the decisions we take are based on the histopathology assessment. So a good expert in histopathology would make the decisions more accurate and more, I would say, better for the patient. Then we have personalized selection for adjuvant treatment. We already addressed the benefit of radiation, the benefit of chemo. There should be a discussion and looking into the adverse risk feature to select the optimum treatment for better oncological outcomes. And finally, in regards to the most recent trial I discussed, we know that sequential chemoradiation resulted in higher disease-free survival when compared to concurrent chemoradiation and radiation alone, mainly for higher risk group post-radical hysterectomy. This is my last slide. Thank you very much.
Thank you very much, Dr. Fawzi, for this very clear, precise, and informative talk, outlining the current issue of cervical cancer treatment, adjuvant treatment, whether chemo, radiation, concurrent, sequential, or radiotherapy alone. Let me leave the floor now to our big boss and dearest colleague and friend, Professor Dr. Sami Al-Khatib, to conclude this meeting from Jordan, Amman. Over to you, Dr. Sami.
No, excuse me. Still, we have Dr. Ahmed Saadeddin.
Right.
We have Dr. Ahmed Saadeddin to be presented. We have a lecture for him.
Okay.
Would you like to present Dr. Ahmed?
مساء الخير جميعا.
مساء الخير, Dr. Ahmed. Sorry, the table I have is ending by Dr. Fawzi's talk.
No, it's yeah, Dr. Ahmed Saadeddin. He's consultant clinical oncologist in Saudi Arabia National Guards, and his main specialty is in breast GI and GU. And Dr. Ahmed, it's a pleasure to have you with us today. And
Yes,
the floor is yours. Did you join? Please share your lecture.
it's always a pleasure to be with you. I'm trying to share my screen. Can you see it now?
Yes.
Okay.
We see the last slide, Ahmed.
You see? Cut it short. Okay. So Sami, as always, has given me a difficult task. You know, what is new in the cervical cancer therapy? And I hope I can say something which you don't know tonight. That's a disclosure slide. And this is my favorite slide. Cervical cancer is another proof that you need to have the team really to serve the patient in a proper way. And I mean it in every, part of it. If you don't have the team, please don't do it. You need to have the team. This is not an uncommon problem. It's the second most common cause of cancer death among women. The HPV story has been mentioned, so we don't need to dwell on it again. I think knowing the anatomy and the virology is very important for prevention and treatment of early disease. Squamous cell always come from CIN, and I think it's important to prevent CIN and to deal with the early disease as much as possible. Staging is very important to keep in mind. I think stage 0 has been eliminated in the new staging books. The one within the cervix, 2 beyond the cervix, but not to the pelvic side wall or lower third of vagina. If it goes there, it's stage 3, and if it goes beyond that, it's stage 4. And there is actually detailed TNM and FIGO staging, which is available for review. Early disease CIN, which is mainly dysplasia treated with, surgery, cone biopsy, or cryotherapy, and so on, while early disease surgery is the mainstay. Locally advanced, where chemoradiation therapy, where our practice is more eminent here, and surgery, if you can do it, but chemoradiation therapy can do the job. The problem is metastatic disease, where you have very little to give in first line and second line. And as you can see, it's basically platinum-based in first line and something to add in the second line, which we are going to dwell on tonight. When we say the updates, I actually done this exercise. I compared NCCN guideline between 2015 and 2021, the most recent version, and surprisingly, it's almost a copy-paste, even the staging. And when you don't see any significant staging differences, you can indirectly tell there's very little in terms of science in that disease, because there's no new data to push you to change the staging system, like what's happening in breast and in lung and so on. The only difference was in stage 3, where you have stage 3C and C1 and C2 pelvic lymph nodes and para-aortic lymph nodes, where even the data behind this new addition is very limited. But to me, this explains that very little has been done meaningfully in the treatment of cervical cancer. Again, when I compared early disease in 2015, 2021, I don't want to repeat myself, and nothing much, almost copy-paste. People who were actually doing the guidelines, they have an easy job to do. Stage 1A, 1B, 1B1 and B2, look at them. I mean, it's almost exactly the same wording. Adjuvant treatment, again, the same thing, nothing much. And whether it's some form of chemotherapy or pelvic radiation therapy, it's actually no significant change since then, which tells you no new data to really support any change. That is that is the, between locally advanced, not early disease, nothing much. Again, I don't want to really go into the details, but the treatment is basically concurrent chemoradiation therapy. When it comes to stage 4 disease, that is the version in 2015. First line combination therapy is basically platinum-based treatment plus minus bevacizumab. category 1, and the rest is actually without category. The second line, as you see, many agents, if you don't use them in the first line, and the only meaningful thing which has been added in 2021 is the consideration of immunotherapy as part of this. Otherwise, it's basically the same thing, compared to 2015. And this is what we are going to try and discuss in the coming few minutes. What is in the horizon? First, adjuvant treatment. I mean, this is a nice Outback study which has been addressing this issue, concurrent chemoradiation therapy, which is the mainstay treatment for locally advanced breast cancer, with or without adjuvant chemotherapy using AUC5 of carboplatin plus paclitaxel at a 3-weekly dosing, which we usually use with ovarian cancers. What was the outcome? As you can see, very little in terms of survival and PFS, maybe numerically there, but actually no significant difference between the two of them. Disappointing. As you can see, the numbers for whether it's local disease or distant mets, one would expect that when you give adjuvant chemotherapy, you'll have significantly lower, at least distant metastasis, but this did not happen. So the adjuvant carboplatin did not do the job, which was sort of disappointing. The story of immunotherapy, why we think of immunotherapy like other tumors. But with cervical cancer, the HPV actually, the high-grade one, the high-risk one, E6 and E7, it induces a cascade of cytokines changes, increasing the BDL1 upregulation and allowing immune dysfunction. So this is one of the medications which have been tried. Libtayo is a new medication, monoclonal antibody against BDL1, has been tested in a phase 3 trial. So they have actually taken recurrent or metastatic disease, and they have enrolled patients who had, one or more lines of treatment, and they have left it to the investigator choice to use the chemotherapy they can use, whether it's Alimta, topotecan, irinotecan, gemcitabine, vinorelbine, whatever. And they compared to the immunotherapy for about 96 weeks or discontinuation because of toxicity. Most of patients were below the age of 65 with a good performance status. Most of them were squamous cell cancer. There was some adeno as well, and of course, most of them were metastatic disease. Data, outcome, efficacy. 50% had response rate compared to 19%, which is really not bad. The overall survival in overall population was 12 months compared to 8.5, and that number was a little bit higher in adenocarcinoma. That was surprising. And this is the dissection of data of safety issues. Nothing unusual when it comes to chemotherapy and immunotherapy. I don't want to dwell much on it, but no significant difference with the or unexpected side effects, which we don't see. Survival in overall population, hazard ratio of 0.69, almost 30% improvement, statistical significance. In squamous cell, a little bit lower, 27%, but again, statistical significant. Adenocarcinoma is even more, 0.56, indicating 44% improvement with a good p-value. So here we have an effective drug compared to chemotherapy with actually better quality of life. That was something which is actually interesting to know about in the last few years. A new class of medications, bifunctional fusion protein called bentrafusimab alpha. This actually fuses itself to TGF-beta subunit and trap it, and actually at the same time it has monoclonal antibody blocking efficacy. It blocks BDL1. Again, I think we are seeing a lot of clever medications nowadays. There was a pooled analysis presented very recently in the ASCO comparing or studying the effect of that drug. These are the dosing, and actually the slides can be pass to Dr. Sami later on if anybody would like to have the data and details. Nothing impressive, but the duration of response was, attention drawer, 23.7 months of response duration, which was very good. Most of it was, stable disease and partial remission, but partial response, but nevertheless, the cohort of patients have been treated, heavily pre-treated. Having this outcome is really good. And there was no clear difference between squamous and adenocarcinoma with this one. And this is the data of overall survival. Remember, the PFS in this setting is not really very impressive, but the overall survival data are really important. And to have median overall survival of more than a year in this cohort of patients with this histology is really something to be aware of. It's interesting. So that's summarizing the 3-1. The Outback did not show any evidence for adjuvant therapy. The Empower study showed meaningful survival benefit of immunotherapy, and the pentrafusum alpha showed promising clinical data, which we need to keep an eye on in the new things to come. Very new things which have been actually also seen in cervical, prostate cancer. Sorry? Okay.
Nothing, please go ahead.
Go ahead, Dr. Ahmed. Sorry.
Sure. The TIL therapy process, this is, like immunotherapy, like vaccination, where you extract the TILs from the tumor, expand it in vivo, and then prepare it with some form of chemotherapy, and then reinfuse it to the patient. That has been tried with this adoptive cell transfer using this drug. And look at the response. The CR and the PR is really very impressive. This is maybe something which we did not think of in future, that to use the adoptive cell transfuse mechanism and to treat cervical cancer. I think it's very interesting. And this is very recent as well. The data is being, I think, tested more in more trials. Back to immunotherapy, and the Keynote 158 is a phase 2 trial where Pembro has been used in pre-treated patients, and the primary endpoint was response rate, and that was impressive in PD-L1 positive patients. Okay, as you can see from this one, the PFS and overall survival, nothing unusual from immunotherapy. Always the overall survival is more impressive than PFS. Another new drug, which I wanted you to know about, is the antibody drug conjugate called tisotumab vedotin. I mean, bear with the names, we are really having a difficult time remembering all these drugs. So it's a protein, which is a drug which actually acts against TF proteins, tissue necrosis factor protein, with multimodal monoclonal antibody activity. Has been tried in this study in patients who really have doublet of chemotherapy with bevacizumab, and they have been given this medication. Look at this. To me, it's very impressive outcome. Most of the patients have some sort of response, and the duration of response was not bad, more than 8 months. In that cohort of patients, it's really very interesting as well to watch. So we are seeing indeed a lot of new ways to think about cervical cancer. Of no treatment available apart from platinum and some taxanes. What are the ongoing trials? Too many. I don't want to, I leave them for you to immunotherapy, but using combination of immuno plus chemotherapy and many type of immunotherapy plus radiation therapy in some sort of patients, chemoradiation plus Pembro, for example, and Pembro for 2 years, very expensive therapy for a long time. I think we are going to wait for the effect of immunotherapy in even radically pre-treated patients. That is the ongoing trial for the vedotin tiso, as I've mentioned to you, but this is comparing it to the investigator choice chemotherapy, and we are going to wait for that. This is another study combining the same medication with either immuno or chemotherapy, and if you give immuno, you continue give chemo, you give with immunotherapy. So we'll see whether, again, sequencing of treatment is going to make a difference in the long term. So there is a lot of data in the horizon which needs to be observed and watched. But in brief, I think what we are facing now in locally advanced chemoradiation radiotherapy is still the preferred therapy in metastatic setting. Platinum first, then you can go for second line with either the drug conjugate or the T-cell immune vaccination. And then if you fail, you can go for clinical trials if it's available. If patients have no prior immunotherapy, you can use platinum plus chemoimmunotherapy. If he has, immunotherapy, you can go for chemotherapy plus bevacizumab plus immuno combo. Use two combos, and you can use the conjugates or the immunotherapy using the transfusing TILs as a vaccine to treat the difficult cases. Clinical trials, I think, needed, and I don't think we are, frankly, at a setting to run meaningful clinical trial in the era, but I think we need to watch very carefully for what's going to happen. So in general, I think the horizon is promising, nothing very definite yet. The basic treatment remains the same. Unfortunately, metastatic disease in cervical cancer is still disappointing, and there is little we can do. Immunotherapy is a window for future, but I think we need to be more clever, understand the disease more, and try to find new medications and know exactly how to use them and to whom we can use them. I think with that, I will finish my talk. Thank you very much, Sami, and thanks everybody for the invitation. And I hope I did not take a very long time of yours. Thank you.
Thank you. Thank you, Dr. Ahmad. And now we'll have the panelists to take the questions and to discuss. After that, we'll give the floor to Dr. Fadi Farahat to give us the closing remarks.
First of all, thank you very much, Dr. Saadin, for your impressive presentation. Actually, I have a question. Do you use the immunotherapy in your practice by your patients, actually in cervical cancer in advanced or unresectable cervical cancer?
Thank you very much, Dr. Nasreen, for the compliment. What we are doing now is actually using pembro in PD-L1 positive patients after failing carboplatin. That is the only platform we have been using immunotherapy.
Okay, so after the fail of the first line or the induction therapy?
My first line is carbopaclitaxel plus minus bevacizumab. We go, and if they fail, I go for pembrolizumab. If they are PD-L1 positive.
Okay, PD-L1 more than one or more
than 1%.
More than. More than one. Okay.
Sorry, I'm not hearing you well. I don't know if it's me or you, but I cannot hear you.
It's okay. Still, if we can add in PD-L1 negative, pembrolizumab is approved plus lenvatinib. So you can use, it was published the last year. So either pembrolizumab in PD-L1 positive, if negative.
If you can afford the financial and clinical toxicity, why not?
Yes, I tried it. It's really toxic. It's really toxic.
I actually, the more I read about combo, the more I'm reluctant to use it. It's really tough, especially for patients who have been through a lot before.
Maybe my colleague answer or
yes. Well, to me, I have to agree with Dr. Ahmad regarding the FIGO staging for 2018. And I think there was a significant change in the staging. It is for the first time that radiology is allowed to be part of the staging for cervical cancer. And it was only a clinical staging. That's beside a significant change in the staging especially for stage 1A and 1B, especially with the definition, as now the width of the tumor is not part of staging, and the reclassification for stage 1B according to the size of tumor. It helped us a lot in determining the best way to perform the surgery. Before it was 1B1, 1B2, more than 4 centimeter, less than 4 centimeter, less than 4 centimeters, we can perform surgery, but which type of surgery depends on the size. But now it is reclassified for 1B1 with tumor less than 2 centimeter, which means we can perform a modified radical surgery compared to 1B2, in which the size of tumor between 2 to 4 centimeters, in which radical hysterectomy need to be performed and not a modified one. So for us as a surgeon, I think the new FIGO staging, it added a lot and it made a significant change in our practice. Thank you, Dr. Ahmad.
Thank you, Dr. Ihab. A very, very interesting comment. You know, as an I've been involved in reviewing some staging for lung and breast and so on. What we would like to see a review of staging which is based on survival data. You see, the review and staging of cervical cancer was actually to help the surgeons to really do or not to do surgery, to do more radical or less radical. But this, unfortunately, was not, let's say, translated into survival differences in the outcome. You know, that is what I did not like in, not, you know, it's simply because we still lack a lot of understanding of the microbiology, molecular biology of cervical cancer. That is, to me, the main thing. We need, maybe in a few years' time, we will learn more about the behavior of the disease, and we will come up with different, look at the breast, what's happening now. You know, the molecular biology is even part of the staging. It's not, it's the nature of the cells. It's playing a part in the way we stage the patient. And I look forward for the day where this is implicated in cervical cancer.
Dr. Saad, I think there is another question. For cervical adenocarcinoma and cervical undifferentiated epidermoid carcinoma, stage 2 or 3, do you propose surgery after chemoradiation? After definitive, chemoradiation, do you propose this procedure?
That is a very tough question. Okay, I hope there is an answer based on science and guidelines. There is no data to tell you whether surgery adds actually to those patients if, for example, their PET-CT 6 weeks later is negative. So chemoradiation therapy, I like the dog. Chemoradiation therapy is a definite therapy, it's a definitive therapy. And, you know, if there is any hint of residual disease, whether radiologically or clinically, I think surgery needs to be done. So I think each case has to be discussed at its own merits.
Dr. Ahmad and Dr. Nisreen.
Sorry.
We have with us some GYN if they want to comment, because I think it's very hard to do the surgery for them after the chemoradiotherapy definitive treatment. So if any of our colleagues,
yes,
GYN, can answer this question or can make a comment.
There is a window of time where you can really after primary radical radiochemotherapy, which is about 4 to 6 weeks following surgery. coming back to the issue of adenocarcinoma or squamous cell carcinoma, I think size for size, they behave the same and respond the same to treatment, chemoradiotherapy treatment, and the surgery more or less the same. The difference is that in the adenocarcinoma, we prefer to take the ovaries out because metastasis of the cervix to the ovary in adenocarcinomas are much higher than squamous cell carcinomas, and survival goes really downhill if there are metastases to the ovaries. The issue of neoadjuvant treatment for bulky regional cervical cancer differs in terms of the bulky adenocarcinomas to the bulky squamous cell carcinomas. I think the bulky squamous cell carcinoma respond better to neoadjuvant treatment before surgery compared to the adenocarcinoma, although they were all retrospective studies. Just a quick last note that in our center, when I used to practice in the United Kingdom at Guy's and St. Thomas, we, for the adenocarcinomas, we used to really do modified radical hysterectomies for all diseases, even the bulky disease, followed by combined chemoradiotherapy straight away, obviously after 4 weeks of surgery, rather than doing the ultra radical surgery for the bulky tumors.
But unfortunately, Dr. Ahmed, this was not proven to really make a real difference in the outcome. You know, I was at the Marsden, we always discuss that. Unfortunately, there's a lot of practice which is not, let's say, evidence-based. This is, you know, sort of out of principle, we give neoadjuvant and so on, but
yes,
you know,
the EORTC 44 or 9941, I think, which was changed during the recruitment phase, only recruited for the bulky tumor without parametrial involvement, and this is what we do nowadays, where a selected group of patients based on really a robust decision by tumor board can be selected for reduction of the tumor size by the neoadjuvant treatment, and that reduces the morbidity and allows for certain cases for fertility preservation. For example, you know, 3-4 centimeters tumors in the cervix in a nullipara or a lady who hasn't had children and you want to spare the cervix, you can give neoadjuvant on individual basis, knowing the risks, proper counseling and all that, and that may allow you to do trachelectomy on her.
Dear panelists, we have other interesting question. Can you take this question?
Maybe I can take this question. Dear colleague, for which patients you may use adjuvant chemotherapy after chemoradiation in cervix? Which patients we may use adjuvant chemo after chemoradiation?
If I may take this question, if you don't mind.
Yes.
You mean, you know, the study have shown that after chemoradiotherapy, there is no proven evidence that adjuvant chemotherapy actually improves survival or even PFS in a meaningful way. So I would use it if I think there is metastatic disease. Otherwise, I think, you know, there is no proven evidence. The toxicity of carboplatin is not simple. So personally, I will not use it unless I have sort of a feeling that this patient might have micrometastases, which I'm not seeing well, heavily nodal disease, you know, large tumors and so on, you know, very high grade tumors.
Okay.
And yeah, I'm more inclined to use it in adeno versus, for example, squamous cell cancer. So that is, but this is all outside an evidence-based sort of practice. I don't know whether my colleagues agree with this.
Yes.
Your colleagues, do you have another idea about this? Yes.
I agree with Dr. Ahmed in regards to it's not adjuvant purely, so there is evidence for radical treatment for limited metastatic disease in cervical cancer. So even if we have a local advanced disease with a distant metastatic site, there is evidence that local regional treatment would improve the overall survival. And in this case, I wouldn't really call it adjuvant. It might be like a maintenance chemo or consolidation, just to that we already know, or if there's a very suspicious site to be covered by systemic treatment. I would also would like to comment on the previous questions in regard to the adenocarcinoma, the adenosquamous disease, when it comes to radical treatment. From a radiation oncology perspective, we tend to escalate the dose to the higher limit when it comes to adenocarcinoma histologies. We know historically that with brachytherapy, we aim to target the disease by 80 to 85 equivalent, gram equivalent. In adenocarcinoma, we try to make this dose between 90 to 95 BD. Thank you.
I think we have a couple of questions for Dr. Bassel. There's one question is asking about is it necessary to perform HPV testing before the vaccination? And other one is how much the vaccination can prevent cervical cancer, and the third one as well about the genetics with cervical cancer. Does it run in families? Those for Dr. Bassel.
Yeah, thank you, Dr. Ihab. I hope Joy is not making noise right now. So,
no, it's fine.
So the HPV, usually we start vaccination around 9 to 11 years old, just before the age of sexual activity or marriage. So if you have the vaccine before your first sexual activity, you don't have to have the screening for HPV or testing for HPV before having the vaccine. For this group who will have the vaccine or who will to have the vaccine outside the context after the marriage or after the sexual practice and want to be sure, yes, you can do the testing either by pap smear or by liquid cytology or something like that. And then if you are free, you can have the HPV vaccine. So if you are in screening program or before sexual activity, you don't have to test for HPV before, but after sexual practice or marriage, yes, you should test, and you shouldn't have the vaccine if you are already have active infection of HPV before the infection subside to protect from the other variants. The other question is vaccination can prevent, because more than 98% of cervical cancer is caused due to HPV vaccine. So simply the vaccination to the high risk 16 and 18, the bivalent or the tetravalent, can prevent more than 98 to 99% of cervical cancer. So it is a totally preventable cancer that you can prevent.
It's very effective. It's very effective.
That is why we said that all the world want to eliminate cervical cancer by 2030 by the vaccination programs all over the world. So it is very effective. More than 98% is preventable. Yeah. For genetics in cervical cancer, we know very much about genetics in ovarian cancer and endometrial cancer, the Lynch syndrome and also molecular. But in cervical cancer, really, it is more or less an infectious due to the infection of HPV. It is more or less some sort of infectious disease, not due to genetics. Yes, there is very limited studies about the role of genetics in cervical cancer and the role of immune therapy in BDL positive patients in cervical cancer, as Dr. Ahmed has stated, but still the main genetic testing is done in ovarian and endometrial cancer, not in cervical cancer, except in the context of immune therapy, something about the BDL and something all of that, up to my best knowledge.
Have we overcome the risk of, at the moment we were saying, does it worth to go to the vaccination because the number of preventive cases is low compared to the full number of vaccinated person? We have overcome this, let's say, this idea. Yes, now it's a must. We can tell our patients that it's a must to be vaccinated twice before 15 or 3 times before 45. It should be repeated. I mean, it's important for us. Yes. Can you confirm, since it's educational?
Yes, I have myself vaccinated my daughters and all the young girls in my family. So I myself, before anyone asked me, I vaccinated my girls, and they are just 11 years old and 14 years old, and they have finished their vaccination program. So I totally believe. Yes, you will tell me that I'm sure that my girls will not have sexual practice outside, and their partners will be okay. But you are not never sure about something in the future, or even about the behavior of their husbands or their partners. You don't know. Everything is changing. Just you have a preventable cancer, and you can prevent. So you can do, if you can afford to go for vaccination until we have registry, and we can do on a public level for free.
I should admit that we are short of that yet. I mean, it's at our society here, we have difficulty to have, vaccination being enforced on people yet. But I think I fully agree that this is a preventable cancer with a simple vaccine, and it should be done. And
yes,
I hope, we will be able to do that very soon.
So we have last question, I think. Oh, 2 questions. Can you take it, your panelist?
Maybe I have a question, dear doctor, for me. What do you think about the vaccination after 40?
No, really, we don't have enough studies to support the use of vaccination. In the United States, they say it may be given up to 45 and 50, but still we don't have solid data that the benefit would be okay. Still, for those women who have very few sexual practice or one partner, they can benefit, but still it is better before 26 years old.
Okay, thank you. Thank you very much.
What about the cost?
The cost in Egypt, the single dose in Egypt costs around 750 pounds, 750 Egyptian pounds. So you have 2 doses before 15, it's 1,500 pounds. This is like less than $100, I think. This is less than $100 for the 2 doses. The 3 doses will be around 2,000 Egyptian pounds, which is like $125. So I don't think it's more or less affordable for many people. Not yet the vast majority, but for many people it is affordable. And if they know about it, they are going to have it. It is available in Egypt right now. I don't know the situation in the rest of the Arab.
Dr. Farhat, it's available by you in Lebanon?
Yes, many years ago, yes.
Okay, and it's by the insurance or
I was thinking about that. I'm not sure. I will ask.
Okay.
But I thought that some insurance will pay it. I think the Sécurité Sociale probably will pay it. It will be smart.
Okay.
It's cost effective. I mean, by simple vaccination, we are preventing for long term. We have to ask if in any Arabic word the insurance will do it. Dr. Saaduddin in
I know that they don't pay it at my side here.
I think it is part of the national vaccination program in Libya and in Emirates.
Yes.
Those are the only countries that can provide it for their population. But unfortunately, in Jordan, we don't have the new one, the 9-valent vaccine. We have the quadrivalent, which is the old one, and it covers only 70% of cases of cervical cancer compared to the new one. And it is not covered by the insurance, and it is not present here as well.
Just wanted to throw a controversial note on cervical cancer, and maybe Dr. Basil can confirm this from data on his oncology center, that most of the cases of cervical cancer in Egypt are really above the age of 55, contrary to the epidemiology of this cancer in many countries in the world where it is a disease of the younger age group. In Egypt is mostly above the age of 55 years, and many really of the studies that were done on specimens did not confirm the HPV virus. But this may be due to fault in the storage or processing of the samples or testing of the virus itself. But definitely the age group is a little bit different, and whether we should go for vaccinating the younger age group only for 2-3 doses and not testing them for the effectiveness of the vaccine at a later age group, maybe 40-45 or not, to see if they need a booster dose or what. I think that needs further assessment.
Yes, Dr. Ahmed, I totally agree that we see most of our cases after 50 years old, but still we see most of our cases in stage 3 and 4 cervical cancer. Almost the vast majority are with parametrial infiltration, with vaginal infiltration. So mostly this cancer has been developed like 10 years before or many years before, like high-grade squamous intraepithelial neoplasia or very early cervical cancers that take some years to go to this advanced stage. If we still have the screening programs, I believe that we will pick up many cases in the early stages before 40 or before like the other groups. But almost 3 out of 4 or like 90 over a percentage of the cases you see after 55 years old or 40, they are far advanced with hydroureter and hydronephrosis and parametrial infiltration, and this is miserable really.
I think there's the last question, but I think Dr. Ihab Arayan is typing an answer. Dr. Ihab, would you please say this answer? Do you perform systematically an aorta caval lymph node dissection in cervical cancer or only in advanced cases?
So performing lymphadenectomy and or para-aortic lymphadenectomy, it's not performed routinely for patients with cervical cancer, but it can be performed if during surgery we found a suspicious pelvic lymph adenopathy, or if we have an imaging preoperatively supporting the presence of significant para-aortic lymphadenopathy. So the answer is it's not performed routinely.
Okay, it's not routinely, only in special cases. I think there's no more questions for this interesting session. It's very impressive. It was very impressive. Thank you very much. Thank you for EMAC, and thank you, Professor Farhat, for this opportunity to be with you.
Thank you, Dr. Sami, Dr. Basil, and everyone. We enjoyed your company today.
Thank you, Dr. Farhat. The floor is yours, please.
Thank you, everybody. Thank you, Tammy. It's a pleasure to see you, Dr. Fadi, and everybody else. And we hope that we will meet in person. خلاص ملينا يا سامي.
إن شاء الله قريبا إن شاء الله.
إن شاء الله.
كلنا رايحين نلتقي.
حاجة virtual, دكتور.
يا إن شاء الله قريبا بنلتقي.
Thank you very much for you all. The ABC Oncology, it's a pre-last session. The last session will have place in December 7. I would like to thank all the participants. I will start with our colleague, Mr. Chairman, for his very nice sharing the session. Thank you, Dr. Sami, for your effort in supporting the scientific activity. Dr. Sekotori, it was a pleasure. Dr. Sami, I also would like to thank our speaker, Dr. Ali Shamsuddin, Dr. Basil, Dr. Fawzi, and Dr. Ahmed Saaduddin Ahmed. It was a pleasure seeing you again. And thank you, Nasreen, Ihab, and Abdullah for being panelists. I wanted only to say that really thank you for the attendees. We reached the number of more than 140 attendance at the beginning and during the meeting, and we with Dr. Sami, the Cancer Research Group, which I preside, and the AMAC under the guidance of Dr. Sami Khatib, we are really happy to have your suggestions to present. So the program will be put soon for the next year, and we invite you all to participate to our activity. Thank you again, and see you soon.
Thank you very much.
Thank you, Fadi. Thank you.
Thank you.
Nasreen.
Thank you, doctors.
إلى اللقاء وبأمان الله إن شاء الله.
إن شاء الله. Bye bye.